this number. Let me get that. Yeah. Anjana, meanwhile, you can read the disclaimer.
Okay. While our president is fixing the voice, let me read a disclosure. API is a disclaimer for telecom on COVID-19. Are you able to hear me?
Yes, it's somehow resounding, but go ahead.
Purpose of API COVID-19 teleconference is for information purposes only. It should not be considered as medical or financial advice. API has no liability as to how this is interpreted. API has no liability for results, losses, damages that may be caused directly or indirectly or incidentally. Please refer to CDC website on your state government health authority for information and updates. Any questions?
Thank you, Vandana. Now, Suresh, go ahead and
Yeah. Thank you. Can you hear me now? Is this better?
Yeah.
Okay. Thank you, Dr. Campbell,
Yes.
Pratap Singh Raghav, speaking on chemotherapy in the era of COVID-19 and immunotherapy in COVID-19 pandemics. Is there a concern by Dr. Savita Balraman? Heme malignancies and COVID-19 by Dr. Madhavi Gorusu. Targeted therapy during COVID-19 crisis, Dr. Shirish Gadgil. And updates on hematological manifestations of COVID-19, Dr. Satish Kattula. And Dr. Raghav is from Houston, Texas. Dr. Balraman is from Michigan, Framingham Hills, Michigan. And Dr. Gorusu from Connecticut, Dr. Gadgil from Michigan, and Dr. Satish Kattula from Ohio. And today's moderators are Dr. Vandana Agarwal from California, and Dr. Lokesh Chidara from Michigan, and Dr. Satish Kattula. Thank you.
Thank you, Suresh. I appreciate your help. And Satish, can you?
Yeah, thanks everybody for this opportunity, and it's a very important topic because cancer is one of the independent risk factors for not only acquiring the infection, but also there is high mortality for different reasons. And most of the cancer patients are elderly, and that leads to more complications and higher mortality. And also patients are on chemotherapy and other therapies which may complicate the infection, the COVID-19 disease. And we do have a lot of immunocompromised patients, and not only on chemotherapy, but also who undergo bone marrow transplants who are immunosuppressives. So these are all the things that will need to be addressed, and that's why we have excellent speakers today to talk about all these topics. And it's my pleasure to introduce the first speaker, Dr. Campbell Pratap Singh Raghav, who is a gastroenterology oncologist from MD Anderson. So I have a good relationship with him, and whenever I have a question about GI oncology, he's my go-to guy at MD Anderson, and he's very prompt and very candid about his, about his opinions and things like that. So he's here with us to speak on chemotherapy in the era of COVID-19. Dr. Campbell Pratap Singh.
Thank you, everyone, for having me. I think this is the largest Zoom meeting I've ever attended. But I'm glad that we're talking a little bit openly about this topic, which I think is actually a very important topic and has probably affected all our lives in some way or the other. In spirit of candidness, let me first tell you that most of the things that I will tell you, as you will read in literature, are often not evidence-based in COVID-19 because if you think about it, this thing has only happened in about the last 3 months. So the amount of time required to generate good quality evidence is just not being the case, right? At least for oncologic patients. I think the best data, I would refer everyone to read a Lancet article, which was published for cancer patients in the SARS-CoV infection. It was a nationwide analysis that actually brought about some really important points that I'd like to highlight before I go into the concept of discussing chemotherapy in the COVID era, right? My expertise is generally in GI malignancies. So the amount of chemotherapy, the severity of chemotherapy, and the risk of COVID infection could be different for different specialties. However, I think some basic principles still stand, right? So in the analysis that came from China, they looked at about all their COVID patients, and about 1,500 or so patients had a history of cancer. Now, if they look at a population-based study, it was about 1% of the entire population. But in China, in general population, risk of cancer or history of cancer is about 1/3. So like 0.30%, right? So essentially what they meant to say was that the risk of this of COVID infection cancer patient appears to be slightly higher given all the caveats, right? Now, in about 75% of those patients, they were cancer survivors, right? So most of those patients actually did not get chemotherapy or surgery within the past few months. Only about 25% of these patients got chemotherapy in the past few months that were admitted. They also found a couple of interesting things about this population and the population that was the general population. What they found was that you had severe CT manifestations of this disease, severe shortness of breath, and they also created a composite endpoint of hospitalizations and intubation. And what they found was that it was significantly more in patients with cancer. And when they divided this population into cancer survivors as well as those that were actively receiving any treatment, they also found that the risk of death and the risk of severe infections was significantly high. So this is the best piece of evidence that we have, but we can conclude from this that the risk for COVID would be slightly higher in the cancer population. And if they contract COVID, the risk of going on to a severe, going on to a severe complication from COVID would probably be higher, which is not unreasonable. Also considering that the comorbidities, again, we haven't adjusted for comorbidities and the fact that our population tends to be older, which they also found. So they also have diabetes, hypertension. So I'm not sure whether it is a population-based issue or it is just a chemotherapy-based issue. But nonetheless, anything that decreases your immune system, one always has to worry about that. The degree of immune suppression, however, can differ in various cancers, right? In GI cancers, for example, most of the times when we give chemotherapy, we're not really worried about viral infections in general, compared to stuff that we might be doing for lymphomas or leukemias, right? Where you're at a higher risk for non-bacterial, non-neutropenic infections. So some of the principles that, so we actually had a discussion, and there are a few guidelines that have cropped up around this from CDC, from ASCO, some groups in, I think, Italy and France, where they have made some general comments regarding chemotherapy in the COVID era, right? So the first basic principle that they have said is, because we are at increased risk, if you can delay start of chemotherapy, then you should do that. Now, it's a very subjective kind of a statement, because how much you can delay chemotherapy in patients is a matter of opinion, right? Like the first time you diagnose a patient, you don't really know what the trajectory of that patient might be. And therefore, our group has agreed to start systemic chemotherapy for metastatic disease, at least for first line, without any delays whatsoever. And of course, we watch patients closely, and also we select patients carefully, right? So an 80-year-old where I would have planned on starting chemotherapy and at least trying something, like maybe start with single agent GEM, escalate to GEM-CIS for, say, cholangiocarcinoma, I would have a better goals of care discussion with that 80-year-old today than I would have had if it was not a COVID-related issue. But for metastatic disease patients, we have decided, at least for first line, we would start systemic chemotherapy. Now, the question is, what do you do for second line treatment? And I think, sorry, I think there's a little bit of an echo. Okay, good. So the question I don't think is first line or second line. The question I think is the relative benefit that you're getting from chemotherapy. And I think like in colon cancer, your first line responses are close to 50-60%. Whereas, if you go to second line chemotherapy, those responses drop down to 30%. They even drop down further to like 10 to 15% for a RAS mutant patient where you don't have an alternate biological. So in those patients, we would try to delay chemo and not start chemo unless and until it's necessary. Going down the line to third and fourth line chemotherapies, we have been fairly resistant to starting any newer therapies such as, say regorafenib for colorectal cancer. Now, regorafenib technically is not an immunosuppressive medication, but it does increase your chances of, hospitalization. And it's an undue stress for the patient, especially in, I don't know what's going on in other hospitals, but at least at MD Anderson, if you get admitted, you're there alone, right? There's no visitors allowed. So I think those factors have to be kept into consideration right now. And again, if they get admitted, then you have to go in and see them, which is, another, you're adding basically to traffic in an already congested system. So if your chances of responses are really low, we actually have been staying away from starting that treatment unless and until the patient is really robust. It has also affected some of our adjuvant therapies. 5-FU for colorectal, I think, has been a very reasonable adjuvant therapy for most stage 2 patients. We haven't been escalating to FOLFOX if there is no requirement for it. In lower risk stage 2 patients, we are foregoing chemotherapy altogether because the chances of benefits are really low. And again, it's not that 5-FU is very immunosuppressive, but it does require you to come in every 2 weeks to get an infusion. And if you get capecitabine, you still require toxicity checks. So if your benefit is in single digits, maybe it is not worth it. Chemo radiation, for example, in rectal cancer, we have abbreviated our radiation and universally adopted the 5-day short course chemo radiation and tried to sandwich this between chemotherapy for like a stage 3 rectal cancer, for example. Similarly, if somebody presents with, somebody presents with a really unsalvageable situation or situations which could be regarded as Hail Marys, I think that at this time, the risk for giving them chemotherapy far outweighs the benefit that you can provide them. I'll stop there and see if anybody has any questions. I'd like to keep it as active as possible.
Satish,
let's save the questions till the end. So let's finish up all our scheduled talks and we'll have about 20-30 minutes for the questions.
Perfect.
So it's a great talk, and the next speaker will be introduced by Dr. Vandana Agarwal.
Next speaker is Dr. Savita Balaram. She'll be talking on immunotherapy in COVID-19 pandemic. Is there a concern? Savita is a hematology oncology specialist and associate professor of internal medicine at Oakland University, William Beaumont School of Medicine. She's also the chair of MAPI Educational Council at Farmington Hills in Michigan. I welcome Savita for giving us a talk on immunotherapy in COVID-19 pandemic. Welcome.
Thank you, everybody. I know this is a very unusual time in all our lives. Definitely in my life, I think this is one of the most challenging times as I struggle with what's best for our patients. I struggle with how we take care of our office staff and our families. So it's very important we discuss evidence-based or anecdotal, because right now, for most part with COVID-19 patients, many of us seem to be flying by the seat of our pants. So again, like the previous speaker said, I reiterate, many of the things that we're going to say are not necessarily based on level 1 or level 2 evidence, based on clinical trials, etc. So what's interesting about immunotherapy is, for long, we have recognized that malignancies happen because of tumor evasion from immunosurveillance. And so the immune system seems to be an integral part in decreasing the ability of cancer development and metastases. So when immunotherapy came about in malignancies, no wonder it won the Nobel Prize, because it acted by restoring cellular immunocompetence and also restoring our immunosurveillance mechanism. So one of the things that we always talk to patients about was the lack of severe myelosuppression, and hence the lack of high risk of infections, etc., when we give immunotherapy as a single agent. This came with fewer side effects, as you know, like alopecia, myelosuppression, but immunotherapy does have its whole different slew of autoimmune complications, and that's where the benefit risk ratio with immunotherapy lies. As we all know, the autoimmune complications of immunotherapy typically happen within the first 6 months, but they can happen at any time. There are a couple of concerns which at this time are considered theoretical, but may become relevant in the realm of immunotherapy for cancer patients. The first is the interstitial pneumonitis that we all know can happen in patients who are being treated with immunotherapy. About 2.5 to 5% of patients with single agent immunotherapy, or PD-1 inhibitors or checkpoint inhibitors, develop interstitial pneumonitis, but this number can go up to 5 to 10% when we add anti-CTLA-4 antibodies like ipilimumab. So when you talk about patients who have pre-existing interstitial pneumopathy from immunotherapy, those patients have the potential of being more susceptible, theoretically, to the SARS-CoV-2 virus, because you have two potentially synergistic lung pathologies, which could then become a huge issue. And this might lead to increased severe respiratory illness in these patients. Again, it is not founded based on any study. It is founded more based on our theoretical concerns. The study that came out of China talked about chemotherapy and surgery in cancer patients. So the data about immunotherapy and immunotherapy-related toxicity in SARS-CoV-2 pandemic is very limited at this time. The concern about the interstitial pneumonitis with immunotherapy is the mortality from interstitial pneumonitis just from the IOs is about 35%. So when you add the mortality with SARS-CoV-2 in a patient who has autoimmune complications from immunotherapy, that number could be a lot scarier. The second concern is CAT scan findings and symptoms in patients with interstitial pneumonitis or autoimmune pneumonitis can mimic the CAT scan findings as well as the clinical features that patients present with SARS-CoV-2. So they could have cough, shortness of breath. Occasionally patients do present with fevers, and when you look at the CAT scan, you can have interstitial changes in early interstitial pneumonitis, and subsequently people develop organizing pneumonia. So distinguishing between autoimmune pneumonitis versus an infectious etiology obviously relies on rapid turnaround of our swabs and any other new tests, including the Rutgers test on saliva. Now, there are some interesting hypotheses that are being generated based on this immune competence mechanism that I talked about. A lot of the SARS-CoV treatment now are looking to cancer therapy as a means to establish immune competence and therefore fight infections. And I would allude to our CAR T cell therapy, where we use CAR T cells in patients with leukemias, lymphomas, now in myelomas, where we do see a robust cytokine release storm. Cytokines are inflammatory molecules that cause severe respiratory and cardiovascular and multi-organ compromise. So when we have these cytokine release storms, we have used anti-IL-6 agents to decrease or overcome the cytokine release storm. Now, investigational agents for SARS-CoV-2 include anti-IL-6 agents like tocilizumab. They're also looking at CD24 antibodies. And the basis of plasma convalescent serum, which has antibodies to fight the virus, is also an immune-mediated mechanism to improve or hasten the clearance of the virus from the human body. So the concern at this time appears to be theoretical. What we have done at our institution is, if a patient needs adjuvant chemotherapy or is symptomatic from metastatic cancer and needs adjuvant immunotherapy, with or without chemotherapy, we talk to the patient at length about the pros and cons. For instance, if we have a stage 4 metastatic non-small cell lung cancer patients where we typically use chemoimmunotherapy as the first line, if the patient is symptomatic, then we use chemoimmunotherapy. But if the patient is asymptomatic, like other times, we do wait for next generation sequencing, which I know Dr. Gadgil will probably talk more about, to see if there are candidates for targeted therapy. We also evaluate them diligently, like in the non-COVID era, for single agent immunotherapy. In patients whose metastatic cancer is being treated with first-line immunotherapy or second-line immunotherapy, if they have been stable for a while, we've had discussions with patients about holding off on the immunotherapy transiently till the SARS epidemic or pandemic passes over, hopefully sooner than later, for multiple risks. One is the theoretical risk of immune interstitial pneumonitis. And the second is the more visits they come to a healthcare institution, the concern of them being exposed to somebody with COVID-2. So these are interesting times. We all are making dynamic decisions, and sometimes we're making decisions that don't apply any longer 24 hours later. So this is where we are today with immunotherapy in oncology with the COVID pandemic.
Thank you, Dr. Savita. Really appreciate it. Next speaker, I'd like to, Vandana, are you there? Can you?
Yes, I am. Yes, yes. Yeah, so the next speaker is Dr. Madhavi Guru. She's a clinical professor of medicine and president of CAPI. She's the chair of the API Plasma Donor Program, and she's in the BOT Connecticut chapter of Leukemia Lymphoma Society. Today she will be talking about heme malignancy during the era of COVID-19. Welcome, Dr. Boruso.
Thank you so much, Vandana, and all the esteemed speakers. Thank you. When I was talking to Dr. Satish Katula about being part of the speaker panel and the hematologic malignancy, once I started thinking more and getting a little bit have an insight of what I'll be talking after my last patient, I finished my notes around 6:20. I was like, oh boy, there's a lot to cover when I agreed to do the hematologic entire malignancy part. But extremely important area like what other speakers have covered. So I was thinking like, how best can I do justice to this time slot allotted? And I thought like, maybe I will go with in the last 2 to 3 weeks, how I have dealt with my own patients. So let me, and I can go with acute and chronic hematologic malignancies. I think that might make it a little bit streamlined. And I can talk about multiple myeloma and myeloproliferative neoplasms, the key points. And the guide that I always go back to when I have any question is, of course, our DMT meetings, our tumor board meetings, and the ASH website, hematology.org. And they have a beautiful, based on the hematologic malignancy, they have put in what the centers are doing, what the considerations. Again, these are only guidelines. Of course, it totally depends on your institution, your patient, those kind of things. So recently, one of my patients, when he was, I had to make a decision about inducing him for acute myeloid leukemia. So for a minute, let's talk about what are the criteria in deciding whether we go ahead, full go with the standard 7 and 3 induction. I would say yes, if a patient is better served with the 7 and 3 induction, then go with the 7 and 3 induction. And the other question comes, are we all routinely doing the COVID-19 testing? I guess, once again, it's institutional based, but I would consider doing a COVID testing before starting a patient on intense myelosuppressive regimen. And anytime if a patient can be served reasonably equally efficacious but less myelosuppressive regimen, let us say with Videsa and Venclexta, the combination of the hypomethylating agent and Venclexta, that is a reasonable way to go. Again, in this way that we can probably do it in the outpatient setting rather than admitting the patients in the hospital. The other things about the prophylactic antibiotic coverage is definitely giving emphasis to an antifungal, antiviral, and an antibacterial. And how are we managing the transfusion requirements? So consideration given that there is and will be looming shortage of the blood units available. Judicious use, of course, based on your patient's symptoms, but maybe the threshold should not be high, but rather considering for a hemoglobin less than 7 or platelets less than 10. Of course, it all depends on if a patient is symptomatic bleeding. That's a totally different scenario. So these are the things part. So that is how I have done with my patient when I had to start him on the 7 and 3 induction, getting the infectious disease service and the prophylactic antibiotics transfusion requirements. So what will happen after my patient completes the induction, the consolidation treatment? So at this time, the consensus is that, yes, your patient needs consolidation, go with the consolidation. But instead of the standard 4 cycles, consider 3. And instead of the 3 grams per meter square of the high dose RSC, go ahead with consideration of 1.5. And what if your patient needs allogenic bone marrow transplant? So I believe at this time, collection of the, again, it's center to center, totally institutional based. But during that time, when the transplant is not imminently right away can be done, consideration of an additional cycle of consolidation treatment while you are bridging your patient until this pandemic cools down. It's one option. So anytime when you are considering these any intensive treatment, consideration of the COVID testing is one thing. The question also comes, let us say if your patient gets infected, I guess this principle can be used for any hematologic malignancy. What if your institutional guidelines offer a combination of the hydroxychloroquine and azithromycin, which can have a potential of prolongation of QT interval? Obviously making sure that the cocktail of the medications that your patients are on do not have that potential for the QT prolongation. I do not believe there has been any clinically relevant hepatic interactions with remdesivir, even though there has been like 60% the transaminases elevate, but nothing ominous to kind of dose reduce any of the things. But again, individual case-to-case basis. So that is my AML patient. Taking another patient that I had to make a treatment consideration is a myelodysplastic syndrome patient. So talking about MDS, myelodysplastic syndrome, as we consider high risk and intermediate risk and low risk. High risk patients, when they need treatment, going ahead with the treatment, I believe is being considered by all the centers, because high risk, they need treatment, go for it. With the same caution about transfusion, like what I have reviewed in the AML setting. And if patients with low risk MDS or the situations where you can avoid initiation of treatment, go for it. And a consideration of supportive treatments like Procrit, these are the, like what we do. Then comes the other discussion about our things like what about in the MDS with 5q minus, with who are on Revlimid. As most of us have heard and seen the emails come from Celgene, instead of the 28-day period, it is extended to a 2-month period, but still they have to do the REMS, the phone questionnaire part. But, and if you have the ability to monitor your patients instead of bringing them to your infusion center, like with some kind of lab arrangement that they can get a home draw and they can get the supply, like because Revlimid is for the non-oncology physicians in the group. It is only given on a 3-week supply. So these are the things that can be done. And so that is about myelodysplastic syndrome. And the other scenario that one of my patients who had to be admitted to the hospital with myeloproliferative neoplasm, she has the chronic myelofibrosis, JAK2 positive, and she has been on Jakafi. So what is the standard? Do we have to stop Jakafi? No. In fact, unless there is a huge, serious COVID infection, those kind of things, because remember, any abrupt disruption of Jakafi, on the contrary, causes a cytokine storm, and patients can present with DIC and clinical worsening. So there is no recommendation to stop Jakafi. And on the contrary, Jakafi seems to have a theoretic beneficial effect in maintaining the cytokine homeostasis. So if there is a patient who might not need right away any cytoreductive therapy, you can postpone that. But considering phlebotomy, like let us say in other myeloproliferative conditions like polycythemia, who can be managed with phlebotomy rather than putting them to cytoreductive treatments. And patients who are already on cytoreductive treatments, rather than bringing them to the office, again, the home draw, these are the scenarios. What are we doing with multiple myeloma? Is there a change in how we are treating our induction regimen? I believe in any patient who needs treatment, be it if it's an elderly patient, going ahead with the daratumumab, Rev, and Dex regimen, and 6 to 8 cycles, and then keeping them on Rev maintenance. And the relatively younger patients with VRD regimen, and again, 6 to 8 cycles and Rev maintenance. If the patient has to be on Revlimid maintenance, I believe at this time, the risk versus benefit, continuing the Revlimid makes sense. Once again, remember the Celgene has eased the restrictions, so patients can get 2 months supply, but still they have to do the questionnaire part. And a kind of the transplant evaluation part, I guess, once again, it is center to center based. And so if the patients, again, can wait for the stem cell collection and in between they continue the current regimen, that is ideal. And again, I'm sure Satish will remind me or Dr. Idara if I'm going behind
Yes.
more than the time. Do I need to stop?
I think you are.
Yeah, okay. So let me pause and yeah, thank you.
Next speaker, please. Vandana, you like to introduce next speaker? Go ahead.
Thank you, Dr. Madhavi, for such an outstanding presentation. It was very informative, but because of time restraints, we have to move to the next speaker. And there will be some question answers towards the end, which Dr. Kathula and Dr. Lokesh Idara will be asking. Thank you very much. The next speaker is Dr. Suresh Gadgil. He's a professor of medicine at University of Michigan in Ann Arbor. And he will be talking on targeted therapy during COVID-19 pandemic.
Thank you very much.
Dr. Gadgil.
Thank you. So my task is to talk about targeted therapy. And before I start, just 2-3 sort of, I don't know, disclosures, but I'm a thoracic oncologist. So I will be talking about targeted therapy in that context primarily. I will also say that we all have changed, adapted, and we are continuing to adapt. So I will tell you that my opinions about 3 weeks ago, or maybe even 2 weeks ago, were different than what they are now, to some degree, because the situation in our hospital, Michigan, has been affected quite a lot. And so the situation in our hospital has changed, and that has impacted decisions. So, you know, one thing to note, and I'm sure you all realize that we are saying a lot of things, but to some degree, it has to be tailored to your own situation and your hospital situation, as well as the circumstances around you. I will say 2 other things, especially in the context of lung cancer patients, that I felt has become very important, is that tumor boards have become extremely important. The virtual tumor boards that we are doing, I think reviewing, making every effort to possible to review pathology and radiology, as well as connecting with your other colleagues, has become extremely crucial in the context of COVID-19. And finally, pertaining particularly for targeted therapy, I would say get your pharmacist involved. We have a phenomenal pharmacist that works with the thoracic oncology team. And I, as a routine, and I think I'm going to do this even after COVID-19, as a routine when I start the patient, particularly on targeted therapy, I'm going to have her look at the ConMeds and be certain that there are no drug interactions, be sure based on the labs that there are no specific toxicities that one needs to be aware of. I can tell you that once you do this on a regular basis, you realize how helpful this is. So I would start off with that. When we talk about targeted therapy, I think the first issue really is identifying the target. And it has become challenging to get biopsies on a sort of routine basis. And there have been some delays, particularly all our bronchoscopies have been discontinued unless it's an absolute emergency. So getting a biopsy can be a challenge in this era. And I think this becomes even more important where we look for ctDNA to identify molecular alterations that can be targeted, particularly in lung cancer. So in most of my advanced lung cancer patients, particularly in the last 1 month, I've been actually sending both the tissue for NGS as well as sending the blood for ctDNA simultaneously. And I know that this probably is busting the healthcare budget, but unfortunately, because we don't know what the tissue will be adequate for molecular alterations, and more importantly, if you're able to identify alteration, targeted therapy in this pandemic probably is the best treatment option, considering the relative lack of toxicities, relative lack of impact on the immune system. And so make every effort to identify targeted therapy. As far as starting treatment is concerned, extremely important that the education is done properly. And so at least in our setting, when I do a virtual visit, I talk about the drug, but we still land up having the nurse do the drug teaching with the patient. So there is a sort of a joint video visit with the patient. We usually have the patient get labs done locally if they live at a distance before starting treatment, and about a week to 2 weeks into starting treatment. And I think that it is very crucial that once you start these patients on targeted therapy, that you do a video visit within, or a telephone visit within a week or so, a week to 10 days. I think the toxicities can become very evident with targeted therapy relatively quickly, and identifying them and addressing them will prevent these patients from getting more sick and coming to the emergency room or coming to some urgent care. And so proactive assessments, maybe even a couple of visits within the first 2-3 weeks may be valuable. I think as far as patients who are already on targeted therapy, I had a routine of getting a scan done, being lung cancer so unpredictable that I would get scans about 6 to 7 weeks, the first scan after starting targeted therapy. I definitely have extended that. I'm going much more on clinical assessment via virtual visit. And if the patient is clinically doing well, I've postponed getting scans done. Though I try and get blood work on a reasonably regular basis, just to be certain that there are no liver or renal toxicities that are emerging. The other thing I would say, and probably the final point, is that as far as duration of therapy, this is the time where one needs to be very mindful of progression. So if you if you see a report of progression, make every effort to try and assess if that progression is clinically significant or relevant. Because clearly patients can benefit post-progression, and this may be a time where you can continue on treatment if there is a slow, minimal progression, instead of just seeing a report that says progression and switching treatments. In these patients right now, it would be prudent to just continue them on treatment and maybe try and repeat a scan in 6 to 8 weeks. Again, as long as the patient is clinically doing well. I would finally say that try and be certain that you know about the main toxicities of these drugs, and very simple things, skin rashes with dabrafenib, trametinib, or sometimes with osimertinib, and trying to address these simple things, but doing it in a proactive way, as well as trying to avoid medications that can potentially interact, God forbid, if the patient got infected, would be very crucial. So that, in summary, is what I would say about targeted therapy. A final thought is, don't miss an opportunity, particularly in this pandemic, to identify a patient who could benefit from targeted therapy and treat that patient, because that may be one of the safest anti-cancer treatment right now.
Vandanaji, thank you, sir. Really appreciate it.
Our next and last speaker is Dr. Satish Kathula, who is a clinical professor of medicine at Wright State University and is a good friend of mine. He will be talking to us on updates on heme manifestations of COVID-19. Dr. Kathula.
Thanks, Vandana. Can you all hear me okay?
Yeah.
Okay, good evening, everybody. So you don't have to be a hematologist to talk about hematological manifestations of COVID-19 because a lot of these are seen by hospitalists and critical care specialists. But I want to briefly touch upon the manifestations which we commonly see in this disease. The first thing is thrombosis, which is very common in these patients. Either it is arterial or venous, but mostly arterial because they have microthrombi, which actually leads to multi-organ failure, as you know, like kidney failure, hepatitis, and even strokes, sometimes gangrene. There are some case reports of that too. And venous thrombosis includes TVTs, PEs, even portal venous thrombosis also was reported with this. So this is one of the main reasons for morbidity and mortality. That's what leads to multi-organ failure. And thrombosis actually is a sign of more severe infection. And definitely on autopsy, 8 out of 10 patients actually in one study had diffuse thrombosis of arterial system, in fact. So the question is, what causes thrombosis in these patients? There is endothelial damage of the arteries as well as venous system. They have increased ACE2 receptors. And there's also an amount of DIC in these patients, like any other bacterial or viral infection. So DIC, we all think about bleeding, but what happens in DIC is clotting first. That's what leads to consumption of all the clotting factors. And the end result is bleeding. But initially, we see a lot of clotting in DIC as well. So all of these factors contribute to thrombosis in these patients. And patients who have cancer, sickle cell disease, and other hypocoagulable states, such as factor V Leiden mutation, prothrombin gene mutation, hyperhomocystinemia, these actually increase the risk of thrombosis in these patients. And the big question is, how do we treat these thrombosis? So what kind of anticoagulation we give, whether it is prophylactic or therapeutic. But all these sick patients receive prophylactic anticoagulation anyway. So they either get low molecular weight heparin, 30 to 40 milligrams once a day, or unfractionated heparin 2 to 3 times a day. And there are some studies which are actually looking at apixaban, which is oral anticoagulant. So these are the things that we consider, but my threshold would be very low to give therapeutic anticoagulation because these people have pretty bad thrombosis, which is subclinical. So any opportunity, I actually give therapeutic if possible, unless there are contraindications such as bleeding. So it complicates things because people have DIC consumption of factors, bleeding, their PT is high, PDT is high, fibrinogen is low, and all these things can lead to bleeding. They have alveolar hemorrhage due to ARDS, and that's why we have to be careful. But we always have to look at risk-benefit ratio as we do it with every treatment. So, but typically everybody gets prophylactic anticoagulation. But if you suspect that there is more thrombosis, and then if there are no contraindications, have a low threshold to start therapeutic anticoagulation. Also, there is a talk about post-discharge prophylaxis. These patients are at risk up to 90 days after discharge from the hospital. Once they have COVID-19 infection, they are discharged, but they can still have the risk of thrombosis. Could be arterial, could be venous. So what do we do in that situation? And people are recommending, there are no proper guidelines, but these are all based on small case series where they're recommending, prolonging low molecular weight heparin or unfractionated heparin prophylaxis for several weeks, at least 5 to 6 weeks after the discharge, unless, until they become mobile, until they become completely healthy. So and even some studies are looking at discharging patients on apixaban. Once they go home, they can be on that rather than injections, but we don't know the results yet. These are all pretty preliminary. And as I said, bleeding is also not uncommon in these patients, but clotting is more common than bleeding. And the next manifestation we see very commonly is anemia. And anemia has so many reasons. I mean, I've never seen any patient in ICU for any reason with normal hemoglobin in the last 19 years of my experience. So this is not any different, but there are some unique features about COVID-19. What it does is it displaces the iron molecule from the hemoglobin, and that's what causes significant anemia. And it also dissociates the oxygen, from the hemoglobin. So the oxygen dissociation curve shifts towards left, meaning that there is, decreased release of oxygen to the tissues. So it's a double whammy, basically. So now you are having all these factors, standard factors, which cause anemia in ICU patients. On top of that, the iron molecule is gone from the hemoglobin, and then, you have decreased oxygenation of the tissues with left shift of the OD curve. So that's what causes a lot of problems, and these people have bone marrow suppression from the viral infection like any others. So there are multiple factors which cause anemia, and iron depletion is very characteristic of this infection. So there are some studies which indicate, or hypothesis I should say, that hydroxychloroquine and chloroquine can actually prevent this loss of iron molecule from hemoglobin. And that's how it can actually, prevent anemia, but we don't have big data to support that. And the question is, when do we transfuse these patients? The thing is, typically we transfuse when the hemoglobin is less than 7. But, with all these things going on, when somebody has ARDS, when somebody's on the vent, and there's so many issues, there is actually, laboratory anemia, which we see, there is functional anemia too. So on top of that, they have lung damage. So my threshold would be low to give transfusion. So I would target a hemoglobin of 8 or 9 to really have good perfusion of the tissues. So that's one thing. And there is a couple of case reports about erythropoietic agents such as darbepoetin. And one patient who was admitted to ICU actually had a full recovery when he received erythropoietic growth factors. But they also received antiretroviral treatment. We don't know which one really worked. But it's an intriguing thought that this can not only improve the oxygen, hemoglobin, but it might work in some other mechanism, but we still need more studies to really prove that. And what other hematological manifestations we see? Leukocytosis with neutrophilia, which is not so common as bacterial infections. It's seen in about 20% of patients. Leukopenia and lymphopenia is also characteristic of a lot of viral infections, including HIV, CMV. So same thing with COVID-19. We see lymphopenia up to like 43% of patients. In fact, this correlates with the disease severity. If the lymphopenia is severe, that means that the disease is also severe. And when the patient is recovering, the lymphocyte count actually recovers. Monocyte count also recovers. And there is decreased number of CD8 cells, natural killer cells. And typically in this, CD4 to CD8 ratio is not reversed, such as in HIV and cytomegalovirus. That's of academic interest. So that's about leukopenia and lymphopenia. And then we see thrombocytopenia not so commonly. It's pretty mild, in fact. And it's present in about 20% of patients. And the other thing is, in lab findings, we see high D-dimer levels. So D-dimer is a sign of blood clotting in the system. And D-dimer is basically cross-linked fibrin. So D-dimer can be elevated due to a number of reasons. For example, any infection, critical illness, and somebody's sick, post-surgery, all of these can increase D-dimer levels. But in these patients, actually, COVID-19, they can be like 20-fold, 100-fold. And that directly correlates with the severity of the disease and mortality as well. But if the D-dimer is negative, it has a very good negative predictive value. What that means is that if somebody has normal D-dimer, the risk of clotting, the clot burden is very low. So that's why, checking D-dimer helps. If it is normal, it's good. But if it is high, that indicates that this is, a more severe disease and there is clot burden in the system. So that's, that it helps with that. So it correlates with other inflammatory markers, including CRP, LDH, fibrinogen, all these, inflammatory markers. So this goes up along with other inflammatory markers. So there are also case reports about antiphospholipid antibodies in the blood of patients who are affected with COVID-19. This is not specific nor sensitive, but we see a lot of patients who have increased antiphospholipid antibodies in other infections too, or any sickness can increase these levels transiently. So we don't know whether this actually causes antiphospholipid antibody increase, and that's what leads to hypocoagulability. We don't know that. It's probably, in my opinion, it's a transient thing which can be increased in other conditions too. There was a question about plasmapheresis in these patients. So how well this plasmapheresis works, we don't have any data again. There are only case reports. So plasma infusion is different from plasmapheresis. Plasma infusion is you just give convalescent plasma, which is supposed to have antibodies, and that's what is supposed to really kill the virus. And but in plasmapheresis, what we do is we give regular plasma, not convalescent plasma, and we take out a lot of plasma from the patient's body, and that actually can help in the sense that when we are giving plasma from other patient, then that has normal coagulation factors. If they have bleeding or something, that can actually benefit the patient. And when you're removing the plasma, you're leaving all the cytokines, you're removing viral load and things like that. It's all theoretical, but we don't know whether it helps or not. More studies are needed for that. So that actually finishes my talk, and we'll be happy to take any questions. And before that, I just want to make a comment. Most of our oncology patients are very, they are well behaved because they know what to do when they get chemotherapy, when their counts are low. And, they are indoors and they wash their hands, they're wearing masks. They're telling other people too what to do. So actually, when I talk to patients, they are not going anywhere. They're just homebound all the time. So that's a reassuring thing for us as oncologists. Now we can take any questions. We have about 10 to 15 minutes for questions.
This question is, can you hear me? Can you hear me, Satish? This is from Dr. Sridevi, who is a Dallas oncologist. She has a 30-year-old with lymphoma stage 2B, and her plan is to start CHOP and RITUXA and rituximab. He's a COVID positive.
Well,
and he had a fever and cough, and we repeated his test. It is negative. He's 3 weeks from his test. Repeat is negative. He's asymptomatic. Planning to start treatment next week. And she's asking all your opinion.
So, well, I'm unmuted, so I probably can take this question.
Anyone else?
The patient is, over the hump. I mean, the symptoms are still there, but 3 weeks, the test is negative. So I think he probably has antibodies. And lymphoma is something, my professor used to tell me that if they have a pulse, you treat lymphoma because it is very curable. And if you don't treat it, then they're going to have, more progressive disease and they will die from lymphoma. So I would say if it is 3 weeks and the test is negative, I would go ahead and start R-CHOP, yes, sure. Unless somebody has a different opinion.
If I may add, I totally agree with Dr. Katula. Am I audible? Yes.
Yeah,
okay. So the only thing is that if at all it's an early stage, whether giving the limited cycles of R-CHOP and radiation, which would have been the standard, if we can limit or take away the radiation part out or limit the days of the radiation so that we needn't expose the patient so many times for the visits and rather give an extra cycle, I believe that is being considered. And also if you can refer to the American Society of Hematology, like the reference that I said, they exactly address this particular topic. Please, you can take a look at that as well. Thank you.
Next question we have is, this question can go to Dr. Savita Balaraman. Can you please discuss DVT prophylaxis for COVID positive patient in nursing home settings? Also, can we give Xarelto as DVT prophylaxis to ease nursing burden.
So are we talking about COVID positive patients who have not been hospitalized or discharged recently? They're
Yes.
just in a nursing home.
It says that she said nursing home, COVID positive patients in nursing home settings. I think you can answer both questions.
Okay, so in COVID positive patients who've not been admitted to the hospital, depending on the severity of the illness, I would assume they are mild, and that's why they're still in a nursing home and they're not in the hospital. I would definitely check their blood count, because we are seeing patients who present with coagulopathy, low platelets, even when they don't have moderate or severe disease. And if their platelet counts are over 50,000, I would not have a problem anticoagulating them with prophylactic doses, though the data is non-existent. There is no data for full dose anticoagulation in the outpatient setting unless they've had a pre-existing blood clot or they have a new acute DVT for any reason. For a patient in the nursing home who's been discharged from the hospital after a COVID-related illness, like Dr. Katula had referred to, we do place them on prophylactic doses of either low molecular weight heparin or any of the newer anticoagulants, as long as they're not coagulopathic and their platelet counts are over 50,000 and not dropping.
How about patients who are admitted? Some say prophylactic plus more anticoagulation in the acute severe patient. COD, serious severe disease.
So based on the severity of the disease, we're also looking at their D-dimers. Again, it is a institution-based decision. There are some institutions that are starting with D-dimers greater than 1,000 with full dose anticoagulation. Some others place them on prophylactic anticoagulation till the D-dimer goes over 2,500, or if they have severe respiratory illness categorized by hypoxemia, lung infiltrates, etc. I would implore the other panelists to add if they have anything else, but I know that it's institution-based, at least where I'm from.
Pratap Singh, sir, do you want to add anything?
No, I think, I think these are reasonable recommendations. Unfortunately, we're in a territory where data is very, very minimal. So I think, making clinical judgment calls is reasonable at this time.
And there's a question about remdesivir available at hospitals. It's only trial, or it can be given remdesivir without the trial?
Currently, remdesivir is not approved for the treatment of SARS-CoV-2, regardless of the severity of the illness. It can only be given on a clinical trial.
I think there have been some instances of compassionate
use.
Another question about I think plasma. About plasma treatment in acute, I know FDA approved, but any case studies on plasma, convalescent plasma on the mild or moderate COVID patients? Any studies done? Any in your practice? Are you giving any patients?
Madhavi, would you
Yes,
want
I
to take
will.
that?
Yes, yeah. So the Mayo Clinic, there are 3 protocols. One is for the mild, the other is for the moderate, and obviously what we all know is for the very sick patients. So, I mean, this is an oncology discussion, but I think regardless of the oncology part, right now where the emphasis is being given to the acutely ill patients, but what I'm seeing here is that definitely the needle is moving towards where patients are at that verge of, to prevent that intubation part, are the patients receiving? Yes, the needle is moving. And I think that is the hope, that once we have more of the plasma donors, awareness, and the blood banks have enough of the plasma supply, then the rationing need not be only towards the severely sick patients, and it should be considered very importantly towards the moderately sick, because like many times we have discussed in these meetings, the passive immunity is more effective if the dose of the inoculum is smaller, meaning that at the earlier phase of the disease rather than waiting until the very end.
Thank you. I think
Dr. Adara, if I may add, it's not yet FDA approved. It can only be given either through the Mayo Clinic protocol, an expanded access, or a single patient IND at this time. They're also looking at an interesting protocol for prophylaxis of healthcare workers who've been exposed to COVID. So that's
Right.
another thing that I thought would be very beneficial to look into.
Yes, Johns Hopkins is doing the study. But when you go into the individual permission, if the pulse ox is 93%, it can be approved. So if I'm a doctor, I want to FDA 3 hours, I can get it, but the plasma is not available yet. So yeah, I have a feeling if the plasma is enough, we'll be moving towards the mild to moderate cases. The follow-up on this question, Savita, you can answer. In the nursing home patients, do we do D-dimers on a patient who are presenting with the COVID-like symptoms, and should we start Xarelto for DVT prophylaxis, and how long? I mean, they're not going to hospital, I think. What do you mean, the nursing home patient, the mild disease?
So I would not base decisions at this time, decisions of anticoagulation, whether the patient is just COVID presumed. So we call it PUI, presumed infected versus not. I would base my decisions on their clinical findings and what I think is their underlying risk for DVT. Just being COVID positive, we know majority of these patients are asymptomatic or maybe mild symptoms. So routinely, there is no need or no data at this time to anticoagulate these patients.
Thank you. Any other questions, Vandana ji or Satish? Do you have any?
Questions? Nobody texted me.
Okay. I have one question myself. We're debating about, we are asthma allergy doctors, we treat our asthma patients with the right. I'm talking to one of the other allergists who's actually, his father died of COVID. He spent himself in ICU 2 days. And his mother has symptoms, but he gave early oral steroids. And 10 patients who come to ER and went back to the clinic, he's giving steroids like a Madral dose pack and Zitropax. The concept behind is any viral infections, we give 5 days of steroids as an outpatient. That's what asthma allergy doctors do. And is any role of oral steroids earlier in the mild cases when the respiratory symptom starts versus your concern about virus and the low dose of steroids?
Maybe I can give a little bit of a very superficial spiel. Definitely, I'm not an ID doc, neither an allergy doc. So in many of the times when we use the steroids as anti-emetic, in fact, we are trying to reduce the dose of the steroid to prevent the lymphopenia. So I guess it is a delicate balance between what is the right dose. I guess it has to be a case-by-case basis, but as far as I am aware, I haven't seen any published literature to support that. But again, this is not my field. I'm just, yeah.
I mean, go ahead.
I was just reviewing the IDSA guidelines, the Infectious Disease Society of North America. Non-hospitalized patients, they say there is no role for steroids. In hospitalized patients, there may be a role for short-term steroids.
That's where we 100% disagree with IDs, because we have 50 years experience of steroids giving and keeping the patients away from the hospital. All asthmatics, when we have 10 tablets of prednisone, when they have viral infection, 90% are triggered by the viral infection. There are tons of mucus that can be prevented, and none of them, our patients, go to the hospital. ID have zero experience in the outpatient prevention of asthma. This is a lung issue. That's where we're coming from. And what he said is, of all the 15 patients or 10 patients he gave, none of them got worse. That's what his theory on that.
You know, it's reasonable. Again, you know, brings us back to that same discussion that, you know, anecdotal evidence does not data make, right? In either cases, right? Like ID is saying we should only give it if, you know, if you are hospitalized, and we are saying we should give it, you know, when they are not hospitalized. We don't have data either ways, right? Like, To be
No,
fair,
we have,
this is,
okay, not in COVID.
yeah, not in COVID per se. And we have to treat this infection a little differently than so many other infections, right? I mean, clearly RSV or influenza, they're not exactly the same infections. I mean, again, if you asked me 3 weeks ago, ID doctors were recommending hydroxychloroquine on everyone, right?
Exactly.
Like they were,
Azithromax.
yeah, and Zithromax, right? So I think data is changing. I think if you do steroids for your asthmatic patients because you think that there is some amount of bronchospasm and that can help, sure. I mean, go ahead and do
No,
it.
not bronchospasm. It's the anti-inflammation, and all the IL-2, IL-6 is at the terminal end. The steroid is the top end. It will block more cytokines than this. That's the earlier part, the sooner.
Yeah, reasonable. But I just, I'm just not a big fan of, recommendations without underlying, evidence as such. Now, individually, what we do is dictated mostly by our clinical experience, right? But I mean, the French study published like 40 patients of COVID, and they said like everybody, felt so much better after hydroxychloroquine. Clearly, that didn't pan out, right? So I think, treating a few patients is not going, ultimately, I think we need to move these patients into clinical trials, right?
Yeah, I agree totally.
So there are 3 questions from Saraswati Mupana. She's a critical care specialist from Boston. The first question is, in my Boston hospital, COVID-19 critically ill patients, we give therapeutic Lovenox in ICU, regardless of their D-dimer or clots. Has that been your practice as well? But I can tell you, in our hospital also, the threshold for starting therapeutic anticoagulation is very low. So if their D-dimer levels are high, they're giving it, but I don't know what others are seeing in their hospital.
What we are seeing is when the patient is ill or sick enough to be in a step down or in the ICU, we're literally, I mean, for lack of better terms, we're throwing in the kitchen sink, right? Because you have very little to lose, but a significant amount to be gained, because 80% of these patients, as you know, depending on the data we read, 17 to 77% of patients who get intubated don't live. So unless they have an absolute contraindication, full dose anticoagulation in those cases, it's not a problem. It's for the mild to moderate where I don't know if full dose anticoagulation would make such a difference. And again, this is not an evidence-based assessment.
And a thing that we have to keep in mind is if truly this is a acute, subacute DIC kind of a picture, our experience from multiple DIC issues has shown us that at some point DIC reaches a place where anticoagulation doesn't really turn patients around. So the question is like, where exactly is that sweet spot where you can turn things around? I mean, sometimes you just may not be able to do anything, right? But again, given in an extremely sick patient, you can do whatever you want because, we know that their outcomes are really poor. But I think to do it in like asymptomatic patients or early patients, knowing 80% patients will recover from this disease, doing anticoagulation is a very big question, right? Like we discuss risk and benefit of that, especially putting patients on newer anticoagulants with higher risk for bleeding and also higher risk for rebound thrombosis if they get off that anticoagulation at some point of time.
There is a fine balance. I mean, definitely we have to look at the benefits and risks. Absolutely. The second question she has is any data on Zygris, which is the activated protein C, dotricobin alpha, in critically ill COVID-19 patients. We use that in sepsis patients. Some studies have shown better outcome with that. But as far as I know, there is no data in COVID-19 patients using this drug. Anybody has any different experience or knowledge about that?
I'm not even aware of clinical trials on Zygris, to be honest with you right now.
I have not heard
for
about
COVID-19.
Yeah. The third question she has is, what day of COVID-19 exactly does the lymphopenia and other lab work happen? Typically in early disease, like 2 or 3, second or third day of hospitalization, those who are getting sicker, their counts go down drastically, especially the lymphocyte count from whatever I read. But those who are recovering, actually it stays stable or the lymphocyte count recovers. So that's the answer for that question. Any other opinions or?
I've actually seen lymphopenia in completely asymptomatic patients, and those are patients I'm now testing. And I've seen a very high asymptomatic rate in those patients.
Wow.
Again, purely anecdotal, but as we know, viral illnesses do cause lymphopenia even in the prodromal or pre-symptomatic stage. And these patients can be asymptomatic for up to 14 days from the time they're exposed. So I'm seeing lymphopenia as one of the initial manifestations of the disease, even before they've been diagnosed.
But Savita, as you know, a lot of our patients who receive chemotherapy or immunotherapy such as rituximab have baseline lymphopenia anyway. Is it the cause or the effect? We don't know.
I'm talking about patients who are not on lymphocytotoxic drugs. That's why I'm saying it's...
No, even you know, I have several patients who get chemotherapy a long time ago and their lymphocyte count is persistently low. And
No,
even
this
with
is acute.
rituximab, you know, you see, you know,
I have
the
a question.
lymphocyte count being low for a long time. It takes about 2 or 3 years sometimes to recover. But, you know, the point is whether it is the cause or the effect. If somebody has a baseline lymphopenia, are they getting infected more? Are they becoming more severe? Or is it because of viral infection, the lymphocyte count is going down? But I think it's the second thing, like any other viral infection, that makes more sense. Yes.
I'm talking about acute lymphopenia, where the patient had normal lymphocyte count a few weeks prior and comes in with a new acute lymphopenia.
Okay.
One question, Satish, all to the panel, because there is a question about an active, I mean, a normal healthy patient have higher cytokine, higher response, being your oncology patient have immunosuppression. Do they do better in COVID or any studies not? Like rheumatoid arthritis? Like
No, I mean, you can answer that question to your allergist, immunologist too, but
we don't have experience.
As far as we know, that's not the case. You know, there is a lot of, opinion about this. Patients who are on immunosuppressives do better because of the fact that their cytokine storm is not as strong. Cytokine release is not as strong as people who are not on immunosuppressives. But initially, people felt that may be the case, but there are patients who are immunosuppressive are really having cytokine storms. So that's not known whether that can have a preventive effect or not.
We have not seen our asthmatics any worse. That's all, at least to our knowledge, but we keep looking for it. There's one question here. Higher mortality after being on ventilators is mostly in patients who did not benefit from IL-6 blocker or convalescent plasma. Is the mortality high even with these treatments in patients on ventilator?
This is a lot of these studies have just been published, and unfortunately the problem is because of lack of like true randomization or true prospective data, it's very hard to say that, right? Like the recent study with remdesivir, which was in New England Journal, they showed like 28% mortality and stuff going on. But, you're more likely to give it to a patient who's more sick also, right? So, I mean, I'm not quite sure we have a handle on this, but, happy to hear any, an ICU perspective of this.
So I don't think the jury's out in terms of plasma convalescent antibody or any of the antiviral therapies, again, because enough randomized data has not been published and enough number of patients haven't been treated on a randomized study. I think the Chinese study was stopped because of some drug procurement issues for remdesivir. And I was told as of today, 4,000 units of plasma have been released. So we should have some preliminary data on plasma convalescent antibody pretty soon.
I think time will tell us. I mean, it doesn't have to be that long. I think in the next 4 or 6 weeks, there will be more studies coming out for all these treatments, including hydroxychloroquine. But we'll see. I mean, I think we are at a point, we probably in the next 4 to 6 weeks, we'll know much more.
Yes. This comment we may need to characterize the T cell population as a possible contributor to the IL-6, CRS pathophysiology or pathway. Yeah. I think
You might be best able to address that topic.
Well, I have to talk to our folks and come back on next meeting, because there is a talk about Th2, even inhaled steroids, the disease severity is milder. So we're going to get more data before I say anything. These are all anecdotal. I have to wait. But if I get it to cold, I think I will take my steroids early, because all allergists believe so. Anyhow, I think
there are actually studies based on T-cell mediated immunity. They're looking at artificially engineered dendritic cells to try and stimulate T-cell immune response. Again, very preliminary.
Sure. Thank you. I think our questions are done. Any closing statements, Savita? You want to start?
I just hope everybody remains safe and the curves not just flatten, but go down close to zero.
Yeah.
That's really sincerely all our prayers.
Yeah. Thank you. Madhavi?
Yeah. And as this is oncology specific, I would say if you can avoid any kind of seriously myelosuppressive treatment and anything that can minimize your patients coming back to the infusion centers, please consider those.
Dr. Kanwal Pratap Singh?
Yeah, I think more important, just clinical decision making, at least for cancer patients, timing of starting chemotherapy, and the burden on the patient as well as the oncologist. I think all those three factors now have to be taken into consideration before recommending chemotherapy for someone with solid tumors at least.
Thank you so much, sir. Dr. Sirish Garcha?
The only thing I will say is one of my concerns as this pandemic has raged on is that we sometimes may not view the importance of the cancer in that particular patient. I deal with lung cancer, and patients even now are much more worried about their lung cancer than the risk of infection. And I in no way want to say that we should not be judicious and be very careful and minimize the visits. But at the end of the day, these patients are dealing with an active disease that may need more attention than the fear of a possible infection. And that balance is very critical.
Sure. Thank you so much.
I just also wanted to comment about caregivers. I think oncology is one area where the importance of caregivers in the patient's physical and emotional well-being has been well documented, caregiver burnout. So making sure that the caregivers stay safe from getting exposed, because a lot of times they're the ones who are going out and doing a lot of the outdoor activities that the patients can't do. So that's another critical aspect that cannot be overlooked.
Thank you so much. Is Sudhakar Jonalgada is here? President? Or Seema Arora? Hi, Seema. He wants. Hello?
Seema, we can't hear you. Can you unmute, please?
Yes, I'm audio. You want to close the meeting? Look, say something.
Okay, can you hear me?
Yeah.
Yeah. Thank you, the speakers, Dr. Kanwal Pratap Singh, Raghav, Dr. Savita Balraman, Dr. Madhavi Gurusu, Dr. Shirish Gadgil, Dr. Satish Kattula, and special thanks to the moderators, Lokesh Idara and Vandana Agarwal, and organized by Dr. Satish Kattula. Thank you all, and especially the audience. And so we are having a webinar every Wednesday and Saturday, so twice a week on various topics. Usually when Wednesdays we are keeping specialty topics, and on Saturday we are keeping general topics. So keep look at our emails. We send out constantly about the topics. Thank you very much for joining, and hopefully we'll all able to control this virus, and so the next generation will be called like pre-COVID versus post-COVID. So it's like BC versus AD. So it will go down in the history. We are living a historic moment, a bad historic moment. Thank you.
Thank you, sir.
Thanks, everybody. Thank you so
Thank you
much.
so much. Thank you.
Thank you.
Good night.